I want to welcome everybody. Happy New Year. This is the January 10th, 2024. Hard to believe. Fellows Virtual Tumor Board, hosted by the American Head and Neck Society. In particular, this month, we're excited to have the Salivary section who have organized this session. Rob Lindow and Nebraska Methodist Health System as our co-moderator with Baba Gibby, who will be joining us shortly out of Memorial Sloan Kettering. Rob, thanks so much for your time organizing this. As you guys all recall, this is 3 cases presented in a tumor board format with some open multidisciplinary discussion. Typically, we try and stick to about 20 minutes per case. So this session is on advanced and unusual salivary malignancies. Anyone joining, please mute if you're not talking, and any questions or comments, just shoot them to me or shoot them to the group in the chat. I'll monitor that and then try and feed them back to Rob and Babak so they can bring them to the group discussion. So without further ado, take it away. Thank you.
Thanks, Dr. Moore, and thank you guys, our 3 panelists for agreeing to present a presentation, our presenters and our panelists. So we're going to start out with Dr. Montalvo from Colorado, Kaiser Permanente Health Systems. He's going to be presenting our first case for us.
All right, thank you, Dr. Lindow, for the opportunity to participate in this educational activity, and good evening from Denver. I'm going to share my screen here and get started. So case I'm presenting, it's a 88-year-old lady who presented initially to her primary care physician with right facial numbness, which she described as initially as very non-specific symptoms, vague discomfort, pressure in the right periauricular region that had progressed to hyposthesia in the right mandibular dentition. She did not have any other signs and symptoms. There was a question at some point of decreased facial mobility, but that's not something that really panned out on exam. And her head and neck review of systems was otherwise unremarkable, with no difficulty swallowing. Very, very healthy 80-year-old female, and kind of this plays into the decision making, which is why I'm emphasizing it. Never a smoker, very independent. She might as well be a 60-year-old, lives on her own, drives, was skiing until recently, has friends, but really no other family, really anywhere, or other social support. So her PCM obtained a brain MRI that demonstrated a poorly infiltrating mass in the deep lobe of the right parotid with concern for perineural spread, followed by an image-guided core needle biopsy that revealed a high-grade salivary ductal carcinoma. This was followed by a PET CT that we can view the images, but essentially had a hypermetabolic right deep lobe parotid tumor, a questionable level 2 node, avid focus in the right posterior mandible, and no evidence of distant disease. So I'll scroll here through the head. I can back it up or slow it down, but essentially we have an 88-year-old lady with salivary ductal carcinoma, the deep right parotid, with clinical evidence of inferior alveolar nerve involvement, stage 4A. Any additional testing or imaging at this point, or any other information the discussants would like to know?
Yeah, and the MRI did when I talked about the nerve enhancement, how much of the nerve was enhancing,
Yeah, so,
and are you talking about the facial nerve enhancement?
So inferior alveolar. So after discussing a tumor board, here, let me go to that. The recommendation was for repeating an MRI cranial nerve protocol, and this did show possible extension of the glenoid fossa and possible involvement of cranial nerves 5, 7, 9, greater petrosa, and the tumor extending to dura through the jugular foramen. The stain for HER2 was equivocal, and FISH testing did not demonstrate amplification.
I know we have Dr. Lee on right now. So from this, with this elderly female with this nerve involvement, the salivary ductal carcinoma, what would you think about radiating this up front without surgery?
Yeah, thank you. In general, salivary gland tumor really is a surgical disease in my mind. Unless the surgeon felt it was unresectable, meaning that there was extensive intracranial extension, it doesn't make sense to do surgery. We will not offer upfront radiation as a definitive choice. Here, I was just trying to study the MRI superiorly. I mean, everything to me, I'm not a surgeon, doesn't look unresectable at this point. Let me see, 5, 7, 9. I think the DORA is what I wanted to look. Frequently, if surgeons can take out all gross disease, that's still going to help me with my post-op radiation therapy. So that's generally my approach.
And do you have a CT scan at all to demonstrate the bone involvement of the posterior mandible?
I don't have it on the slides, but so that was the recommended treatment that we discussed with her, surgery, as Dr. Lee just alluded to. But going back to this, very, very healthy, functional 88-year-old who has a high emphasis on quality of life, being independent, very concerned about cranial neuropathies. She really wanted to think this through, and the conversation that one would have with her, morbidity of surgery versus inferiority of non-surgical management. I mean, what we can discuss that.
Do we have a surgeon on, Dr. Moore, do you know right now?
I know Trevor's here, and it looks like Dr. Hoey's on as well. Babak is here. I don't think there are additional surgeon discussants. I think any one of us are happy to comment, but yeah.
Yeah, I'll throw it out to you, Dr. Hackman. What do you think about surgery in this case?
Yeah, I joined on mid discussion, so I saw the scan. I would kind of agree that from a surgical perspective, it still seems like it is resectable, but I didn't see all the imaging, but there's the caveat that you may not get all microscopic disease, so there'll be follow-on therapy. I guess the question was, I guess this is a patient with a salivary ductal carcinoma, and so the question is this hormone receptive or hormone sensitive? Like, is it HER2 positive? Am I hearing that correctly?
It's not. Yeah.
It's not. Okay. So you can't do androgen deprivation.
Correct. Yeah.
Yeah. So in general, I think trying to get as much gross total resection would make sense in these cases, but obviously it would require quite a significant resection.
Do you have a, can you go back to one of the images, to the CT or MRI that you have? Yeah. Yeah. So obviously bad tumor in a bad location. Salivary ductal carcinoma, highly aggressive. It looks like do you have any nodal disease?
No obvious nodal disease. There was a level 2 node that was very has subtle avidity, and there is an avid focus in the right posterior mandible that was questionable for dental inflammation, infection versus a focus of tumor there.
It's this is a tough one. I think surgery is the most effective treatment, but I don't think any surgeons would be happy at the end of that operation.
Yeah.
And regardless of what kind of surgery you do, you still definitely need adjuvant treatment. The question is, he's older with non-surgical radiation, how much you can halt this tumor. I don't think the radiation will melt it away. Do you agree, Nancy? And if there's any other targeted treatment that can make a meaningful difference in the outcome, not that I know of, especially if it's HER2 negative.
Yeah, and I would agree, and I would say that also if you radiate it, you're going to have potential for exposed bone, osteo, other issues. And so while surgery has a lot of potential consequences from a standpoint of cranial neuropathies or other issues, resecting and then potentially putting healthy tissue in the area and then radiating may be overall less morbid, although a much more aggressive surgery than radiating up front.
And what would be the surgery that you would recommend?
Go back to the MRI. So
And
basically,
it was-
at this point, you need a negative margin surgery, whatever that takes, at least grossly total negative margin.
Was the facial nerve functioning pre-op?
It was, yeah.
Yeah.
Yeah, I think just a couple comments. I think you're going to almost certainly leave the operating room with microscopic disease somewhere. Anytime you have multiple cranial nerves impacted, the likelihood of clearing those, even if you can pathologically clear them on frozen section, there are a lot of small nerves that you're not seeing that you're not clearing in reality, especially in that location. It looks like it's tracking down kind of along the styloid process. So if you're trying to get as oncologic of a surgery as possible, would probably require a lateral temporal bone resection, or at least draw out the mastoid and the styloid base as a part of it. I think the big question, and we'll have to get the comments of the group on this. So if you have a functional facial nerve, the risk of microscopic positive margins is very, very high. When do you resect the facial nerve and when do you not? At least in my practice, I consider taking it if it's going to change the overall margin status, meaning if I have positive margins somewhere else that I know I can't clear along an area of the skull base or something that otherwise can't be cleared, then I would tolerate a close margin right along the nerve. But typically I would resect the nerve if it's grossly involved with tumor. I mean, there are times where you have a fully functional nerve and all the stylomastoid fat is taken up by tumor and you're going to have to resect it. So a fully functional nerve does not necessarily mean you're going to be able to save it.
Yeah, I completely agree with that assessment. If I know I'm going to leave gross tumor behind, I would sacrifice that nerve. But what about the mandible?
Yeah, mandible is another issue. It's, we always sometimes focus on facial nerve, but because taking somebody's mandible is not without problems here. If this tumor is truly in the jugular foramen, I don't think any of us will get grossly positive, negative margin with good margin. So if you're leaving disease everywhere behind, the question is, should you take the mandible as margin? At least in the MRI, it doesn't look grossly involved. The question is the tumor stuck to the mandible or is it going to come off of it? And same as the comment that Mike mentioned about facial nerves goes here. If you can take this off of the periosteum, probably not a bad idea. And if you can't, then the mandible has to go. Or you can just go for a break and just go as wide as possible around it, take it all out, understanding you're still going to leave tumor behind on the jugular foramen probably. And if that dura enhancement is true, correct tumor, then again, you're going to leave tumor behind. Unless you ask your to the middle cranial fossa.
They had tongue sensation?
I'm sorry?
Yeah.
I was just asking, do they have tongue sensation?
She did have tongue sensation, yes.
Yeah, I just asked because, it's probably going along auriculotemporal nerve, getting to inferior alveolar nerve, potentially right around where they're about to join V3 at ovale. So, certainly that's one margin you may well at least could attempt to clear at the skull base, and usually you would have to take out the condyle and a little of that posterior ramus to get access there. But may well still be able to preserve the lingual nerve, basically right before it joins. Kind of take that and the middle meningeal artery branch as it's kind of the auriculotemporal forks around it, and then check a margin right there to see if you can preserve it. I didn't mean to interrupt. I don't know if that was Trevor who it was.
No, I think that's a great point, and I would echo what the other surgeon said, which is that you're unlikely to get a negative margin with this resection outside of doing, like Dr. Gibby said, a middle cranial fossa resection, even then. And so I guess my mindset was, if that patient has a functional facial nerve, I'll do my best to save it, knowing that I'm probably not going to clear disease at the jugular foramen. Same thing with the mandible. And I think the patient has to be prepared for the fact that there may be, even with preservation of the nerve, a dense facial paralysis, and a potential need for sacrifice. But I would probably try to save as the mandible if it's not involved, but understand that she might need a condylectomy, and then that's going to affect crossbite deformity or mandibular occlusion. But I still think that trying to primarily radiate it, there's going to be issues, even if it's effective in therapy, with trismus and function in general. So I would still try to resect, understanding that there is the potential for leaving microscopic disease. And then I guess the question back to our discussant is, what would be the role of intraoperative radiation therapy versus just doing adjuvant radiation therapy?
Great question. I think this area, it's going to be difficult to at least put, for example, a HEM applicator or brachytherapy. You're going to still need to do external beam. So I don't think there's much gain in upfront intraoperative radiation. Some centers may want to put some brachycatheters, but you're dealing with bone and tight space. I think you're going to wind up with more necrosis. So in general, what we've been always doing is do adjuvant external beam radiation therapy, whether IMRT or proton, to allow us to shape the field better. And plus, this is high grade, even though clinically there is no evidence of nodes, the salivary duct is very lymphatic, prone. So we probably have to treat the neck anyway. So it'll be a big field. So I don't think role of brachy is indicated here.
So Nancy, you've done this for some time now. Let me ask you this: have you ever been happy if you have primarily radiated the high-grade salivary carcinoma, the one that didn't have surgery, just, so the surgeon or the patient didn't want surgery and you ended up doing radiation? What's been your experience, or what we do know about primary radiotherapy in these cases?
Yeah, in general, we don't, right? But I did have a case where presented our own DMT. It was like a T50 tumor. It was unresectable, period. So that's when we do alternative. And generally, I use a quad shot approach, which is aggressive palliation. We tell the patient it's really an aggressive palliation. We can get durable control.
7, 5, 6,
for a
8,
while.
1, 1, 9, 4.
Okay.
about
And then I was a little bit surprised, I have to admit. I used quad-shot proton therapy using the biologic effect of proton. I could get it controlled. We don't melt the tumor away, as one of the prior speakers said. We just prevent it from growing. And then these patients can have distant metastases. And then you really just want to control this, not be a problem. And then if they wind up having distant metastases, deal with that. But it's not my upfront recommendation.
Awesome, thank you. All right, let us know what you guys did.
Yeah, so excellent discussion, and I agree, and this is what everything that was mentioned is what we discussed with this very very nice lady. She met with 2 head and neck surgeons, and she met with radiation oncology, she met with medical oncology, palliative care. We made all of the points of possible need to remove the mandible for possible facial nerve paresis, leaving behind a gross tumor. But overall, that surgical resection, and this was considered a resectable tumor, was the recommendation. But ultimately, she decided to pursue radiation therapy. So she tolerated it very well, but about 3 months after the end of treatment.
When you say radiotherapy, was it the full dose 70 grade definitive RT, or as Dr. Lee said,
it was
quad shot?
It was definitive. Let me pull it up. It was definitive, but it was presented as Dr. Lee alluded to, as a palliative. But yes, it was a full dose.
Okay.
And after about 3 months, she noted discomfort in one of her molars. She saw an oral surgeon who saw mucosa that looked abnormal. It was biopsied and demonstrated progression of disease. An MRI was obtained, and it demonstrated complete response at the primary site. But as was mentioned by one of the discussants, this tumor does metastasize, and there were new lytic lesions and progression of hypermetabolic lesions in the right mandible, but no distant disease.
What to do now, huh?
Yeah, so this is the MRI, and you can see there all along the body of the mandible up to the right parasymphyseal mandible. There is recurrence with really nothing in the primary side. Thoughts on next steps and any role for molecular profiling, biomarker analysis?
So I guess
So I think
rare manifestation of a rare disease, which is, very good response in the primary. And did you guys do a chemo RT or RT alone?
Just radiation. When
Just
she met with the medical oncologist, as someone mentioned earlier, they felt that with a HER2 negative FISH analysis, that there really wasn't anything that they could add.
Well, let's ask Dr. Lee. So, Nancy, looks like the radiation saved the day, but now we have this weird phenomenon. How would you approach these problems? Do you question the biopsy? Do you ask for a rebiopsy? Do you ask for a full resection? Do you readjust radiation field?
I am trying to wrap around the field. Do you happen to have the fields of radiation? Because it's so weird how it's it just doesn't
I
make
mean,
sense.
I read from the radiation report, they treated the primary site at full dose, level 2, the posterior mandible, and then lower doses in the neck. And I hope I'm saying that correctly, kind of, yeah, in the neck and away from the areas of tumor.
Sure. And then, but then can you go back to the MRI? It was just, I'm like trying to figure out what happened here. Because if you look, like, it's like in the mandible, it wasn't there before, right?
That was that lytic lesion that was lit up on the.
There was one and I can go back here.
Yeah.
Yeah, there was one focus that on the PET CT was called probably inflammation from odontogenic origin, but it was concerning for
But the MRI, can you go back to pre-radiation MRI? I just don't, maybe I didn't just remember,
I
yeah,
don't
that.
think
And
the
then,
one that I put here goes all the way to the, yeah.
yeah, because I kind of want to see what that mandible look like pre-treatment.
Yeah, I didn't include the whole, but yeah, there wasn't anything obvious there on the pre-treatment MRI.
Because then I think that wasn't in it. So in my thinking, the fact that there's gross disease now in the mandible and probably wasn't included, because we generally don't include a mandible if we don't need to because of osteorated necrosis rate.
Right.
So given she or the patient ADA tolerated well, complete response primary, maybe we can go back and consider radiation in that area. I mean, unless you want to operate, and then reconstruct the mandible.
Yeah, I was we have to move on to the
Yeah.
next case, but I just wanted to, that is a question that I would ask the surgeons in the room. Would you resect that mandible now because we've controlled the disease at the skull base and that's the only site of the disease? Would anybody resect and reconstruct the mandible?
Yeah.
I think I would consider it, but I think you also have to this is 3 months post-treatment. And I think that we are equating radiographic complete response with that there's no disease at the skull base. And I think that that is a very dangerous assumption. So just because there's been a great response to the skull base does not mean that there's not cancer there. And if you're assuming, like Mike said, that there's tumor along the inferior nerve and you have marrow space involvement, I think it would be somewhat naive to suspect that it's not going the other direction towards the pons and the skull base. So just because the MRI says it's negative doesn't mean that it's actually pathologically negative. And I think the patient needs to be made aware of that.
I agree. And in the interest of time, I would say exactly as Dr. Heckman said, if I'm going to go, I would rebiopsy it. I would prove that there is cancer. And it's the same cancer. It's nothing new. I make sure that everybody on the tumor board is behind me. I'm very clear with the goals. And if at the end I would do it, I would be reluctant. But, you know, if everything fits okay and we can go with recon option, you'd go to war with what you have. And if that's the only case, I'm trying to be dogmatic. All right, so what do you guys decide?
So again, we discussed it at Tumor Board, and all of these great points came up. And she again met with two of us in radiation oncology and medical oncology and palliative care. And this time she decided to pursue surgical resection, understanding that this is a very aggressive diagnosis and very likely to recur or metastasize distantly.
What did the path show?
Yeah, and yeah, she had a persistent or progression of disease, high-grade salivary ductal carcinoma along the mandible, and she's awaiting post-treatment imaging. So,
Okay, so
And
she
in
had
your
surgery,
pathology-
uneventful, and pathology was the same and negative
the
margin?
same negative margins at the mandible. Yeah.
And did they
Really?
see radiation changes? Because if you dose that to 7,000, you're gonna see it.
No, you know what? Not commented
Yeah.
on the
Because I feel like it's probably not in the field, right?
Yeah,
Yeah.
you're probably right. Yeah.
Okay, that's
Wow,
interesting.
Yeah,
yeah.
so I mean, thank you. Great discussion and really great points and learning. From it.
Excellent. You definitely win the prize for the most unusual presentation of this disease.
That's the
Okay,
first
Rob,
one, so
thanks.
we'll see.
Hey, Tabitha, you ready to go on your case?
I will stop sharing my screen, sorry.
Think I should be up and going. Can you hear me now?
Yeah.
That's good.
Awesome. Okay. Well, I have a case of a 72-year-old gentleman, very nice guy, who had a 2-month history of a right preauricular facial mass. This was kind of right at the near start of COVID, and of course had a big swelling in his face, got COVID. Nobody would touch him for a little while. Finally got in to see his primary care provider, and they ordered an ultrasound, and then they ordered a needle biopsy following that ultrasound, since he was found to have a mass in his right preauricular area. He has a pretty pertinent past medical history that 7 years ago he had a liver transplant. For the past 3 years, he's been on the lowest dose possible of his mycophenolate and his tacrolimus, but still on some chronic immunosuppressant. So then he got sent our way, and we got some additional imaging. So I am not quite as tech savvy to throw all my videos in, but here are some CT scans, a few screenshots, just of some axial CT scans that I thought demonstrated this preauricular mass pretty well. And so to make up for my tech savviness, I'll say that, he had this kind of infiltrative mass that seemed like we didn't have a great plane along the masseter at the time of imaging. Did not really encroach onto the stylomastoid foramen. There was a good distance between that and the mass on our imaging. And then anteriorly, we do all of our CT next with a puff cheek protocol, and anteriorly we could see some thickening that just went right along his salivary duct over the masseter up until the buccal space. So here are the PET images and the green arrow sign that our radiologist put on there for us.
Okay. And do you guys have an MRI, Tabitha?
I did not have an MRI on him. Well, I did.
What's your practice? Do you routinely get MRI for salivary tumors?
So that's a great question. Not necessarily. So this patient had a fully functional facial nerve going into it. I don't always get one. For most malignancies I do, but I didn't get those put into this area. But he did not have any enhancement along the nerve near the stylomastoid foramen at all.
Dr. Heckman, what's your practice? Do you routinely get MRI for salivary tumors?
I apologize. I just picked up my daughter from lacrosse, so I'm in transit, so I missed the initial part of that presentation. You'll have to go to somebody else. My
No worries,
apologies.
no worries. Rob, what would you do in your practice? Do you routinely get MRI for salivary tumors?
Typically not if the CT scan and the PET scan showing the mass. I do not typically get an MRI.
Okay. Mike, what do you do?
I do for the majority of them. I think if it's a real straightforward one, I don't. But certainly, if there's any question of paraneural extension, I would.
Sure. And I see Jeff Liu joined. Jeff, if you can make a comment, what would you do? Do you get an MRI for everybody?
No, not everybody. I get a CT, and I apologize, I'm trying to cook dinner at the same time. I get a CT scan of the neck on everybody. And then the
Yeah.
MRI, if there's specific questions, like the last case, which is a fantastic case, you want to really do a good deep lobe assessment or see relationships, I get the MRI for sure. Just the timing of getting MRIs tends to delay the overall episode of care.
Yeah. I know our practices, we like MRI here, but that's different. Okay, go ahead. Do you have any question for us, or would you like to proceed?
I don't at this point in time. I have the coronal images that just kind of show this same views and show the thickening there along the duct. So this is he did additionally have some ipsilateral FTG avid nodes. And what I didn't mention before was that what his needle biopsy showed when he came to us was just malignancy. And so they didn't further differentiate that for us at all. We didn't seek any additional biopsies, trying to sort anything out additionally going forward. And so
let me ask Dr. Lee. So this is a great point. Dr. Lee, how much do you twist cytopathologist's arm to give you a better diagnosis? Because this happens at our institution quite a bit. Like malignant, we don't know what it is.
You mean me? We go straight, as you know, to our pathologist, and then we ask for staining if there's possible, and we ask them, is it squamous or not? Because if it's squamous, I'm thinking skin cancer, right?
Yeah.
And if it's adeno, I'm thinking something else. So it's really important. We generally don't have a report just say malignancy.
And I think that's a great point. And the point of this discussion is, salivary gland, especially on cytopathology, could be very tricky. It could be difficult. It's not that the pathology don't, it's just hard. And sometimes it's on us as surgeons and people who treat them just to really push for more information, for more staining, more testing, because as Dr. Lee said, it does make a difference, especially with a person with a liver transplant. That's different, and with it kind of a weird pattern of the tumor that looks like it's going around the duct. So when you look at it, is it a salivary tumor? Is it a metastatic tumor? Seems like a primary salivary tumor, but that doesn't mean that it couldn't be a metastasis, like a lymph node metastasis from the skin. So I do encourage all the folks to try to have a very informed conversation with the pathologist. And to be honest with you, nowadays, with more and more Foundation 1, you can also even get more mutational data. All right, so.
Yeah, and that's a great point. This actually was done at an outside small hospital institution. So by the time we got it in and got it reviewed, the patient had actually called in and said, this thing seems like it's getting quite a bit bigger.
Yeah.
And in that circumstance, immunosuppressed patient also thought, probably we just need to go and work off of what we have. So, so we formulated an operative plan for him. And, we were planning to do a right nerve sparing total parotid and a right neck dissection and resection of this overlying skin that was adhered. And since we were planning to take some skin and we were planning that this patient would probably have a likely need for adjuvant radiation therapy, we were planning on bringing up free tissue to the area already.
Okay, so. Let's see. Mike, would you approach this differently? So patient immunosuppressed comes to you, the tumor is growing in front of your eyes, and all you have is malignant.
And they have a history of skin cancers overlying it or adjacent to it?
No.
Great question.
Yeah, great question. I didn't give that out earlier. So no history of cutaneous lesions on this side of the face at all. One tiny squame remotely treated, very superficial in the past, but none. And we also had our dermatology oncologist look them over really well and didn't see any additional cutaneous lesions that were of concern.
Yeah, I think with the information at hand, unless there's other options of, repeat biopsy that won't delay things or things like that, typically would recommend pursuing surgery. If it were thought to be a cutaneous met, which is still obviously could be, I know the transplant history makes everybody a little questioning the concept of neoadjuvant immunotherapy, but it actually, as you guys know, has been used in that context. It was with fair safety to the organ and actually a reasonable pathologic response, albeit not as robust as somebody with an intact immune system. I do think would still offer surgery. It'd be the standard of care with it extending. Essentially, it looks like in the area where the tumor was from the masseter to the skin, I would think there's a high risk of losing the facial nerve branches in at least that central part. I would imagine they're kind of the mid-face branches around where that duct is. And you have to talk to them about the possibility of needing to track the whole duct into the mouth. And I've seen it where tumors kind of track along the duct and you have to resect a little window of mucosa in the mouth and then just close that part primarily. And then, in that same conversation, talking to them about, what the appropriate reconstruction would be. This one, if they don't have nodal disease in level 1, the submental flap would actually be a great option to rotate into the parotid bed and the preauricular skin.
Okay. Rob, you're a microsurgeon. What kind of recon? This case comes to you.
Yeah.
You're trying to leave town and they say, okay, can you do this quick?
Yeah. So I'm a firm believer that these need to get reconstructed with either free tissue transfer or submental island flap. And if I use a free flap, it's going to be typically a vastus lateralis, sometimes plus or minus skin on that, so that we get the parotid defect filled and we have nice soft tissue coverage over the mandible, and then the skin to reconstruct the skin. But a lot of times you can pull the skin together primarily, so it's usually the muscle that I want up there. So I'll typically use a vastus lateralis, but I've been using the submental island more and more because I do think from a cosmetic perspective it's a very good reconstruction for these patients.
And Dr. Lee,
I love the submental arm flap that Mike suggested. I will put a plug in for a lateral arm flap. This is a great place for a lateral arm flap because it comes with a nerve with it. So if you have to do nerve grafting, it's all done at the same time, and the contour deformity and the closure is very straightforward.
Okay. And Dr. Lee, would you consider preoperative radiation or any radiotherapy? No. Okay, let's move. In the interest of time, let's see what Tabitha decided to do.
So intraoperatively, this patient had everything was stuck. So masseter was stuck, deep tissues were stuck, everything that you would kind of expect from seeing this growing in front of your face. And so as we came down to the main trunk of the facial nerve, we identified it and came anterograde. And right before we hit the PES, everything was just stuck in tumor. So as we're taking it off, we biopsied some tissue adjacent to it just in the interest of time. And that was positive for squamous cell carcinoma at this point in time on frozen section. So they gave us a diagnosis. A frozen diagnosis at this point in time, which we were, very much suspecting going forward. And so the decision then was to go ahead and sacrifice the nerve. The nerve itself didn't appear, frankly, blown out, but it was wrapped in tumor, immunosuppressed patient. And so we sacrificed the nerve. We did not have like an otologist on hand or anybody who was really happy to drill everything out. But if we needed them, we could have gotten them. But we were able to get a negative margin extracranially on the main trunk of the nerve, and then anteriorly, had to take the masseter, had to take a fair bit of facial mimetic musculature as well. This ended up on final path report being a 4-centimeter keratinizing squamous cell, which our pathologist said they favored a primary salivary gland tumor. We did indeed do just what Dr. Moore said, which was go forward and, trace the duct all the way, take some buccal mucosa overso in that area. And there were 10 of 39 nodes, which were positive with extranodal extension as well for this patient. So I use in my partner did the resection. I did put up an ALT in this area. And then we just did a little bit of a fascia lata sling to kind of help support that side of his face. And had a pretty good sized skin defect ultimately that we were covering as well. So I opted not to do a motor nerve to vastus lateralis nerve graft because of how close we were at the skull base on the stylomastoid foramen. So
unfortunately, we don't have a pathologist now, but we still believe in 2023 that there are primary squamous cell carcinoma of salivary glands? Dr. Lee, I see you shaking your head.
Yeah, almost never. I mean, he doesn't have a history of skin cancer.
He had a small squame from like his contralateral earlobe, but he had no squames on that side of his face at all, ipsilaterally. That's one of the only ones I've seen our pathologists actually frankly say that they favored a primary salivary gland squame in the path report, but
yeah.
I've had one case in 15 years of a patient with first bite syndrome as their presenting symptom and ended up having a primary squame of the parotid with no skin cancer. So I think it's extremely rare, but I think it's possible. I guess the question to the group would be, what's the merit of you open up, you lift up, you biopsy the tumor if it's squame? Would anybody back out at that point and just do a biopsy and then do immunotherapy prior to doing surgery?
Great question. I don't know.
Transplant?
Yeah, we don't know if the answer. But this patient obviously is the answer is a little bit easier because he has liver transplant. So and especially with the liver, there are diverging opinions because some people think that immunotherapy is not as bad. Some people think absolutely not. So for this case, I don't think doing surgery up front is wrong, especially with this volume of disease. Would you consider, Nancy, to do just primary? Let's say we knew that this was a squame and we assume it's coming from a skin. Would you consider definitive RT, understanding that probably immunotherapy is not an option?
Yeah, I mean, the role of radiation immunocompromised patient, the control rate goes down, right? At least by 50%. So I think if we can operate, it's probably better.
And then let's say this patient comes to you after surgery. They did a great job with the surgery. And you get a PET scan and everything else is good. Obviously, with the extranodal extension, would you recommend RT plus CCRT, or you go by that New Zealand study that say, well, RT, alone is adequate, say as good as chemo RT? How would you approach this?
I mean, if you look at the NCCN guideline, I think because of New Zealand study, it would be RT post-op. But I always feel like, I need some help, especially he's immunocompromised. So I will have our medical oncologist consulted and then discuss and present to a board.
And I see a great comment from Dr. Weed saying high-grade mucoep sometimes can look like a squamous cell carcinoma. Great point. I agree. I think this patient with the liver transplant definitely would benefit from genetic testing and Foundation 1, MSK Impact, we do it here, or other fusion panels to rule out this is a salivary tumor or not.
Can I ask one question for Dr. Howie, one of our reconstructive surgeons, too? What he would do from a reconstructive standpoint for the facial reanimation at that time of surgery?
Dr. Howie.
Is he on still, or did he?
I think he might have logged off. I don't see his name.
He was on, but I wonder if he stepped off for a second. Yeah, he was on there before.
But I would throw that out to the group then too, about the reconstruction for at the time of surgery, especially in the setting of radiation, and how much you would do, what you would do.
Yeah,
I'll just be real quick. I know we got to go to the last case. I would do a cable graft at the time. Certainly for that size of a defect, I would probably have done a thigh free flap and a nerve graft. I know lateral arm is also a great one that looked a little big, at least from my experience, but I know some people could do it. You can get, and then obviously if the upper division's taken, you could do like an eyelid, wait for that. Some people will rotate the ants up for the lower and then just do a cable graft for the upper just to try and drive as much as you can. Or if you can't get a proximal nerve, you could drive it with the masseter nerve to use that to try and drive the upper.
So Tabitha, what did you guys manage this for after surgery? What did you guys decide?
So patient went on and got 66 gray of radiotherapy to the parotid bed and the neck, and then they came back about 6 weeks after completing radiation therapy. And I biopsied this, and this was once again squamous cell just superior to the flap in the kind of reconstructed, kind of in the previously operative bed. So we actually had a discussion, even discussed with him potential loss of his organ, but we did move on and give him some Keytruda at this point in time, and then re-irradiated that area because they felt as though maybe they were right at the margin of their field there when they looked back at their radiation planning. And so did about 6 months of immunotherapy with this re-irradiation. And unfortunately, the patient on his next set of imaging had liver metastases that he had developed.
Did the Keytruda, did the immunotherapy help with this? Did it shrink?
It didn't significantly shrink, but I would say that it didn't rapidly progress in this area either. While he metastasized elsewhere, this kind of stayed stable.
Okay. Just a very last comment from Dr. Lee, and then we're going to move on. Nancy, if you see this situation, would you rather start immunotherapy first, or you would think of immuno plus radiation or just radiation?
I think if it's really a marginal miss, we might have to think about going back and match the radiation, but it's going to be difficult to do that because there's always dose fall off. So I would consider immunotherapy. I would definitely don't do it concurrently. There's at least 8 to 10 randomized studies saying that concurrent radiation with immunotherapy is not going to work, right? Sequencing is important, but definitely don't do it concurrently with radiation if we're going to give IO.
Excellent. Excellent. Well, super challenging case. Very interesting. Great job with you guys. Again, for all the audience, transplant people, you see in math, it's a skin cancer until proven otherwise. All right. Rob,
all right, Elizabeth.
Yeah.
Yes, let me share my screen here. Right, are you guys seeing the notes, or are you seeing the actual presentation?
We see the notes. We see the presenter.
All
So
right.
just switch your displays.
Pop it, yeah.
Give me 1 sec. Is that better?
Swap. Yeah.
Good. Okay. So this case, and I'll try to keep it brief, just being respectful of everyone's time, is kind of a little bit of a different flavor for a salivary gland malignancy. So we have a 67-year-old lady who came in actually to see one of our rhinology anterior skull-based partners who had this prior history of some right-sided epistaxis, epiphora, and then some nasal obstruction, as well as some right facial fullness. She had been seen by an outside general ENT in the community who did a nasal endoscopy and actually had done a biopsy of a right nasal cavity mass. The patient didn't have really any other associated symptoms other than listed above, no vision changes. She thinks that it had been ongoing for actually a couple years prior to her presentation, heavy smoking history, but no other kind of environmental work-related exposures. So on her presentation, you can see the right side of her nasal bridge and kind of upper mid face is full and expanded as compared to the left side. This was just a clip of her initial nasal endoscopy, again, by our rhinologist. So you can see some kind of fibrinous stuff and probably some cautery artifact and whatnot, who knows, from the prior biopsy, but that's septum to the right of the screen and then inferior turbinate to the left. So she underwent an MRI skull-based protocol, and this identified a 3.6 centimeter mass, was in the right anterior nasal passageway, and just kind of benign versus malignant considerations. She also likely had a little cyst present. And it was really difficult to determine kind of or differentiate middle turbinate and inferior turbinate, but felt pretty confident they didn't see any orbital invasion or skull base, anterior skull base involvement. And this is just a still shot. I also don't have videos, I'm sorry, but just a still of a couple different samples of her initial MRI, just capturing the anterior extent there on the upper right and some of the kind of orbital extent on the upper left. And then the lower screens, again, a little bit, maybe questionable involvement of the canalicular system. You can see there in the lower left, maybe some cystic stuff going on. But overall, the orbit itself looked okay. And you can see a little space there along anterior skull base with the ethmoid cell.
Great case.
So the biopsy came back as a pleomorphic adenoma. We did review her, and part of our process is requesting outside slides, as it is for most multidisciplinary tumor board conferences. And with the snip of tissue that we had, our pathologist reviewed it and said, yeah, I think I agree. It looks consistent with pleomorphic adenoma. And so then the question was, what do you do next? Do you have presumed benign pathology? So what she underwent was an endoscopic and combined open resection, that she basically underwent resection of the middle and inferior turbinate. She underwent an ethmoidectomy, and then she had this resection with a DCR at the same time. The open approach was really to address the kind of the lateral nasal wall, and she had a planned lateral rhinotomy. After her skin incision was made, it was found that she had just kind of bony expansion in that area. There wasn't actually any concern for skin involvement at the time.
Great. Okay, I don't think I've ever heard of a pleomorphic adenoma in the nose or around that.
Right.
Now let me be the devil's advocate. When you were with the MRI, was it very bright on T2? Did it look like a pleomorphic adenoma on the MRI?
Not particularly bright. So this is the T1 post-contrast imaging, but T2 not particularly bright.
So this is actually, it has a lot of enhancement.
Very enhancing.
The T1 post-contrast. And, this could be an adenoid cystic.
Well, stay tuned. So you went through,
So
and
the point is, give me 1 second. I'm going to ask some of the surgeons here. Let's ask Rob. I guess Rob might be involved in this case. Dr. Weed, if somebody tells you show this and say pleomorphic adenoma, what would you do? Do you re-biopsy this, or you say no, it's pleomorphic adenoma?
It is so odd. I'm trying to wrap my head around it. Yes, I definitely think we need to review the slides like what we do for all cases. I'm sure every center does that, and then maybe consider additional tissue. Was it a chunk of biopsy material, or is just like a small,
it was small fragmented pieces essentially. So I think, to your point, it was not a particularly representative large cross section of tissue.
Dr. Hackman, what do you do? If you
can. I agree. I would look at that scan and say, I've never seen a pleomorphic in that location, and the scan doesn't look like a pleomorphic. I would probably re-biopsy it. And I probably would do just an endoscopic approach and not the open and stage it, because the endoscopic is fine. Once you open it, then you're stuck with whatever you open. So I probably would try to do what I could endoscopically as a staged procedure, get more tissue, and then realize I'm leaving a small amount behind and come back for a second stage once I had more pathology. But that's, again, the benefit of hindsight of listening to this case at tumor board and not dealing with it up front the day that it came into my clinic.
Wow. I think this is a perfect case for being skeptical, Dr. Weed, Don, are you able to make a comment? How skeptical are you in these scenarios?
Pleomorphic adenoma in the nose, I think we would all agree, extremely unusual. And any really small biopsy, when you have a very unusual answer like this, you've got to, I think, get more tissue to know. And so an endoscopic rebiopsy makes a lot of sense. I can't tell, I'm on my phone, if this looks like it could be nasolacrimal in origin, or if this is just a sign of nasal presentation. If it's nasolacrimal, that raises a lot of different possibilities as well. But regardless, I agree that another biopsy would be helpful. But I think we are leading with a lot of benefit of hindsight.
Fair honesty, I would not look at this case. But the point is, for our fellows who are joining us, the salivary gland, there are two things that bite you: wrong imaging, wrong histology. And that happens all over. The imaging is extremely important in salivary glands. regardless of where they are. Even if it is simple parotid, imaging will help you, will kind of organize your thoughts. And the biopsy is the king. And I will tell you right now, your biggest battle with your pathologist is going to be on salivary gland biopsy. And you have to twist the arms to get a answer. Just malignant, just not malignant, could be this, could be, it's not going to cut it, because that's all going to have differences in your practice. So just remember that. All right, let us know what happened.
So resection and final pathology consistent with an adenoid cystic carcinoma, both cribriform and tubular types, no perineural invasion identified, staged as a T3N0 MX. Positive margins, right? Surprising, no one. And so kind of now, what do you do with this patient?
Okay.
And we could discuss further. I can just continue pushing forward. So we
Give us 1 minute.
Yeah.
With the surgery, were you guys happy? What was the interface of the tumor with the tissue? Were you able to get it unblocked? Was it in pieces? How did the surgery go?
Yeah, so just full disclosure, I actually inherited her down the road from a reconstructive perspective, and now I've taken over her surveillance care because one of our partners left. So I wasn't in her initial surgery, but a portion of it did seem well circumscribed, involving sort of middle turbinate, inferior turbinate tissue with some submucosal extension in that area, but it was taken out piecemeal, because oftentimes with these endoscopic approaches, as you all know, you're kind of going in and it's tough to remove all the tissue on block.
You know, I am old enough to remember there was an operation called medial maxillectomy without endoscope that would have been good for this operation. But again, with the involvement of the lacrimal duct, I think this is a tough one. This is a tough one. So I can't blame anybody for not being able to take the whole thing out. Okay, well, I guess in the interest of time, we all know that in NCCN guideline or even salivary gland guidelines, adenoid cystic is the only tumor, I think, that even on T1 you recommend RT. Dr. Lee, what would you recommend here?
Yeah, definitely RT post-operative. We don't treat the neck for adenoid cystic unless it's involved. We would trace the nerve. I guess in this case, in the nasal cavity V2, I would go back to Meckel's cave to make sure that and probably even V1, right? To make sure we adenoid cystic carcinoma loves the nerve and they can skip. So we just want to make sure we cover that well in a subclinical dose, and then the postoperative bed to typical 60, positive margin maybe 66 gray.
Dr. Lee, question for you. I know that we do like imaging here at the Memorial. If you do imaging before you're starting your adjuvant, and let's say you get an MRI or CT and you see maybe a little bit of not enough tumor left, how strongly do you twist Mark Cohen's arm to go back and do more?
First of all, I would biopsy, we always do this. And then the surgeons always get mad at us. But for me, I just want to make sure there's no gross disease. So then if it's grossly positive, then I will ask typically the surgeon, can you go back, clear out all gross disease for me before I radiate? Because the dosing is different, right? Because for example, if this patient had gross disease, I'm going to ask my medical oncologist to give some platinum to make the radiation work better. If it's microscopic, then the rollout chemo is very controversial if needed at all.
Okay, so let me ask the surgeons now. Let's say this patient had great surgery, but there is a little bit left. We did the biopsy and it is positive, and it's iffy to go back. But for adenoid cystic, Dr. Hackman, how enthusiastic would you do this?
So I would go back. And the question is whether the part you're going back in is endoscopic or open, but I would go back. And to the point earlier, there was no perineural invasion on the pathology, but if this was endoscopically resected, then there's a chance that you missed the perineural part because of the endoscopic aspect, the piecemeal resection part. So perineural invasion in a parotid removal and submandibular removal is one thing. In an endoscopic case, when you are distorting the anatomy, you may miss the perineural. And so I would just assume that it's there, and I would go back.
Okay. Then in this case, just to catch Dr. Lee before the time's over, you would recommend RT plus chemo?
Definitely RT chemo is it's positive margin. There was an RTOG study. We're still waiting for the results to report out.
Yeah.
It is a phase 2 randomized study between post-op RT versus post-op RT plus weekly cisplatin. And this patient will fit the trial. We're still waiting for the results, whether the additional chemotherapy added anything to radiation. So we will have a discussion with the patient. It is in a bad location, so the person's young, I probably would consider it, because if a failure here is going to be nasty, right? I think we would all agree.
Yeah, I think that's NRG
And
1040. Go ahead.
And Babak, to your point, I think this is a case where if you're going to do it endoscopically, then doing a lateral rhinotomy or Lynch incision combined with it, so you can endoscopically mobilize inside, but then take out the other part from an en bloc approach externally, probably makes a lot of sense, and that's probably how we would think about it.
Yeah, exactly. And you know, again, if we had a biopsy of a adenoid cystic or even the mucoid, then I think all of us would have approached it very differently. Although you as you said, you still do endoscopic because it just gives you a better view of the inside the nose, but it's a different operation. All right, Elizabeth, it's 8:05.
Yeah, so she declined radiation therapy.
Okay.
And she followed up for about 4 months for serial debridements, et cetera. And then she was lost to follow up for 18 months.
Okay.
And then she came back and she had fairly clear recurrence when she was seen again by our rhinologist. She had an MRI, she had a PET, and there were 2 concerning sites for recurrent disease. So this is, you can see she didn't have great syncing of her alignment of her PET and her CT there, but you can see the picture on the right. She had some anterior recurrence and then on her PET, and then she has some posterior sort of PPF area recurrence.
Yeah, that's the V2, right? I mean,
yeah,
we need to cover. Ooh, this is bad.
Yeah. So biopsy the larger site, and this was again positive for adenoid cystic. And now what options? So again, just in the essence of time, we discussed her again. We talked about radiation, but the concern was in this location, she might have some issues with vision sparing. Again, we think her orbit isn't directly involved. So we talked about re-resection, and we had a very clear conversation with the patient that if she's going to undergo resection again, we strongly recommended radiation therapy. It wasn't quite, we won't re-resect you if you don't agree to radiation, but we were pretty strong in our recommendation with her that she needed to go through adjuvant therapy postoperatively, and she was in agreement with that. So she underwent revision, medial maxillectomy, and open ethmoidectomy, and then pterygopalatine Freeman resection endoscopically, and had some reconstruction with our oculoplastics person and one of our facial plastic reconstruction people with a paramedian. So she went through all of this, and that larger component from the PPF area was a PT2 cribriform pattern, adenoid cystic with negative margins that was actually able to be taken out more on block. And again, didn't see any PNI. I don't know why. I mean, we presume that it's there.
Okay.
But felt good about the margin status at that resection. And then she did go on to receive additional radiation therapy and completed that successfully.
Right. And then Dr. Lee, in the second, just the last question, would you, in this scenario, second surgery, 2 foci, would you do RT, chemo RT? Would you do proton? Would you do standard care? What would you do?
I think it is not unreasonable not to use proton, but we will use proton only because the orbit is very close. And definitely in this case, it recurred. I would definitely highly consider chemotherapy with the radiation. And then I would make sure my field is not small. But just like earlier, you know, you need to trace. I would definitely go back to the Meckel's cave, because now you got gross disease in PPF. It's a matter of timing. It was up to B2 and goes Meckel's cave. So I would definitely dose that area to like 50 gray, something subclinical. You're not going to hurt the temporal lobe. And then trace all those nerves, make sure we don't miss anything.
Yeah. Okay, great. Yeah. It's already past a fantastic cases. Thank you so much for all for presenting and participating, Dr. Lee, Dr. Hackman, Dr. Weed, and all the others, and Rob, my friend, and Mike. 2 comments. One is, Dr. Spiro recently passed away, and he's the one who wrote all these papers in Salivary. His comment was, adenoid carcinoma is a tumor that if the patient or the physician lives long enough, it always comes back. So don't think of, if you get negative margin or anything, that it's not gonna, it's just a bad disease. And number two is, I always remember everybody that Gabriel Grunwald, who was a professional runner and unfortunately had a parotid adenocystic that metastasized to her liver. And this woman was so brave that she continued to compete after a liver resection, and unfortunately, finally succumbed to the disease. So with those two comments, just remind you of the adenocystic can happen anywhere and anytime. Thank you again. It was a fantastic night. In the interest of time, Mike, if you have any lasting comments.
Yeah, just wanted to thank all the presenters. Great job. Very thought-provoking cases. Last one's a perfect prelude to our next session. On February 7th, we have multidisciplinary approaches to sinonasal cancers. That's going to be hosted by the skull-based section. So excited for that one. Thank you, Babak and Rob, for organizing, and Trevor, thanks for your help with being a liaison as well. Dr. Bradford Bell, Dr. Manasova, Dr. Galloway, and Dr. Lee, awesome job. Great cases, great discussion. So thanks, everybody. Thanks for being a part of this. Look forward to seeing you next time.
Great job, everyone.
Bye. Thank you.
Thank you. Good night.
Take care.